Hello and welcome to this critical care teaching video on the management of intracranial hypertension. In this video, we're going to look at what is normal intracranial pressure and as a result, what kind of values represent intracranial hypertension. We'll look at which patients we should consider monitoring intracranial pressure in. We'll look at various methods of how we can do that. And then we'll go on to look at your targets that you should be setting for yourself when managing a patient with a traumatic brain injury. And finally, we'll look at what you can do for your patient if intracranial pressure is elevated. So firstly then, what is normal ICP? Well, a normal value for a supine adult is somewhere between 7 and 15 millimeters of mercury. And therefore, by definition, you could consider anything higher than 15 as intracranial hypertension. However, the recent 4th edition of the Brain Trauma Foundation guidelines have set figures of greater than 22 millimeters of mercury as the threshold for treatment of intracranial hypertension, and that's because values higher than this are associated with an increase in mortality for your patient. So who should be having their intracranial pressure monitored then? Well, the same set of guidelines state that all salvageable patients with a severe traumatic brain injury, and that is a GCS between 3 and 8 after resuscitation and an abnormal CT, should have intracranial pressure monitoring in place. However, we would also consider it in patients with a severe traumatic brain injury and a normal scan if there were 2 or more of the following, that is an age over 40, any motor posturing, or hypotension, systolic blood pressure less than 90 millimeters of mercury. There are a few other groups of patients we should be considering monitoring ICP in. These are people who are at risk of a raised ICP when they're under anaesthetic, however they're undergoing a non-neurosurgical procedure. People who have intracranial disease which is not going to be operated on, but they are intubated for other non-neurosurgical reasons. This prevents a clinical examination. We find this with a lot of our patients who maybe have a mild traumatic brain injury but severe polytrauma to the rest of the body, and for that reason we can't wake these people up and examine the neurology early. We also would consider it in people with moderate head injuries but are at high risk for deterioration, and some centres are using it in subarachnoid hemorrhage as well. So how do you measure ICP then? Well, there are many different ways of doing it. The gold standard is considered a catheter placed through the non-dominant frontal lobe into one of the lateral ventricles, an external ventricular drain, an EVD. Commonly though, you'll see subarachnoid screws or bolts in place. These will often have intraparenchymal monitors placed through them. You can also monitor ICP with epidural transducers or indeed subdural catheters as well. ICP bolts, intracranial pressure monitoring bolts, are certainly the most common method we use in the centre where I work. It's placed by sterile technique through the frontal-parietal suture in line with the pupil. It can be done at the bedside in intensive care. The device is then zeroed at the level of the external auditory meatus, and the actual pressure transducer itself will penetrate through dura into CSF or within to brain tissue itself. And it's held in place by that screw, that bolt, holding it into the skull. These are relatively straightforward to insert. As I say, they can be done at the bedside in perhaps half an hour or so by a relatively junior neurosurgeon. They are less invasive and therefore less potentially damaging than an external ventricular drain. They do give high fidelity waveforms. They are small, which makes managing your patient quite straightforward. You can also monitor other things through them, most commonly brain oxygen tension, and they have a relatively low infection rate. The literature quotes around 1%, but I must admit I've seen hundreds of these put in place, and I'm yet to see an infection from one of them. In terms of cons though, I guess infection is certainly a possibility. That transducer tip may not rest where you want it to. It may be resting on top of the brain rather than within it. It could become obstructed and give you abnormal readings. And there is some debate about where it should be placed. We typically place them where I work in the non-dominant frontal lobe, which for the vast majority of people is the right frontal lobe. However, some authorities say it should be placed within the area of brain with maximum injury. Others say you should be placing it within brain that hasn't been injured. You also can't do anything therapeutic through a subarachnoid bolt. With an external ventricular drain, you can take CSF off to help reduce intracranial pressure. You can't do that with a bolt. And they often underread pressures as well, especially when you're getting to values greater than 20 millimeters of mercury. Once they're in place, they can't be calibrated, although some bolts don't require external calibration, so that's less of a problem with more modern kit. And there is a degree of baseline drift, and they become increasingly inaccurate as time goes by, especially when you're getting 5, 6, 7 days down the line. An EVD, or external ventricular drain, is considered the gold standard for monitoring intracranial pressure. It's placed at operation in theatre through a small burr hole directly into a lateral ventricle, and then it's connected to a transducer which is zeroed at the level of the external auditory meatus. EVDs have a lot in their favour. They're considered the gold standard for monitoring intracranial pressure, and that ventricular pressure is considered more reflective of global ICP than subarachnoid pressure or pressure in a non-dominant frontal lobe that you would get with a subarachnoid screw, subarachnoid bolt. They are certainly less prone to occlusion, and they allow the therapeutic withdrawal of CSF, something you're not going to get with a typical ICP bolt. You also get a measure of brain compliance through this. They are relatively cheap, and new devices that are impregnated with antibiotics have been coming onto the market recently, which have resulted in far fewer infections than perhaps we saw 10 or 15 years ago. However, they are more difficult to insert than a bolt, and you are passing through the brain, potentially causing damage on the way. They do put the patient at risk of infection within the ventricle, of ventriculitis, which can be devastating to the patient. They can't be put into people with coagulopathy. Hemorrhage is a risk even if blood clotting is normal, and if they're not looked after carefully, we can accidentally vent CSF through them, which is not a good thing for the patient's brain. Your ICP monitoring device will give you the following kind of image when connected to an appropriate monitor. You can see in this particular series of graphs that I've given you arterial blood pressure at the top and intracranial pressure at the bottom, and you can see in this particular case quite clearly that the P1, the first wave of the intracranial pressure, marries up exactly with systolic blood pressure as well. Interpreting this waveform is important because it can give you a lot of information about what's happening with your patient. If you've got a flat ICP trace, you should consider that your transducer may be kinked or not reading properly. It's often an equipment problem rather than a patient problem there. If you see high amplitude but with no increase in your mean ICP, this is typically a sign that you have an increase in intracranial volume and a high compliance within the system, typically seen in perhaps more elderly patients whose brains have shrunk over time. If you see P2 greater than P1, that's significantly abnormal, and irrespective of what's going on with the mean intracranial pressure, that's something to be worrying about. That shows a reduction in compliance. These are often patients that go on to start spiking intracranial pressure in a few hours. These are not patients to be doing sedation holds and trying to wake. If you see the waveform broaden even further, again, that's a worrying sign showing further increase in intracranial pressure. When you're looking at physiological targets on traumatic brain injury, things are actually very straightforward because what you're after is normality. If we look at the airway, what you're after is normal oxygen levels. A PaO2 between 10 and 13 kilopascals is absolutely sufficient for your patient. When it comes to breathing, we look for normal carbon dioxide levels, or more specifically, lower end of the normal range. And that's typically values between 4.5 and 5 kilopascals. With circulation, because you've got an ICP monitor in place, you can target cerebral perfusion pressure rather than mean arterial pressure. Your CPP, cerebral perfusion pressure, is equal to your mean arterial pressure minus your intracranial pressure. and the monitor at the bedside will work this out for you. Values between 60 and 70 millimeters of mercury are absolutely fine for your patient. You do not need to be pushing their blood pressure higher in traumatic brain injury. Within D, I would look for normal glucose in my patient, values between 6 and 10. Low values of glucose put your patient at risk of further brain injury due to neuroglycopenia, and high levels will potentially lead to further swelling as the sugar will suck more water into brain tissue and worsen edema. Temperature, again, you're looking for normality, or more importantly, avoidance of pyrexia. We saw from previous talk on intracranial physiology that if temperature rises, blood flow to the brain increases, cerebral metabolic rate increases, and therefore intracranial pressure goes up. So you're looking to really avoid pyrexia. A normal temperature, 36 to 37 degrees C, is absolutely fine. A few other potential targets. We're still recommending targeting a hemoglobin greater than 100 grams per litre, or 10 grams per decilitre, depending on the units that you work on where you work. However, there is increasing evidence that actually that may not be necessary, and a more relaxed transfusion threshold of 70 to 80 grams per litre of hemoglobin may be appropriate. There's some large randomized controlled trials going on right now to try and answer this question. We would typically look to maintain serum sodium at the higher end of the reference range, typically 140 to 145. And intracranial pressure, we'd be looking for values less than 22 millimeters of mercury, in line with the Brain Trauma Foundation guidelines. So if we look at cerebral blood flow versus oxygen, then we know that low oxygen tension will increase cerebral blood flow. And that's because the brain is crying out for more oxygen, it's causing local vasodilatation. But if you increase the volume of blood within the cranium, ICP will go up as well. You should be looking to maintain oxygen levels between 10 and 13 kilopascals by titrating your fraction of inspired oxygen on the ventilator and ventilator settings to recruit lung tissue. This may mean that you need high levels of PEEP and high levels of recruitment maneuvers as well. And this may have a transient effect on ICP. But avoidance of hypoxemia is absolutely key in managing patients with traumatic brain injury. And a very brief period of slightly raised ICP during a recruitment maneuver may be entirely appropriate to avoid longer term damage caused by low oxygen levels. In terms of carbon dioxide then, we know again that high levels of carbon dioxide within the blood cause vasodilatation. This again causes a rise in cerebral blood flow and a rise in blood volume, and ICP will follow. However, low levels of carbon dioxide cause vasoconstriction. So although, yes, that certainly lowers ICP, it can impair blood flow to the brain, which can be damaging. So try and keep values between that 4.5 to 5 kilopascals. And this is about titrating your respiratory rate or tidal volumes or inspiratory pressures on the ventilator, and therefore your minute ventilation. You may need values greater than 6 mils per kilo ideal body weight. So you may be drifting slightly away from classical low tidal volume lung protective ventilation. That's a balance that you will have to make for the patient in front of you. Which is the bigger risk to them? A slightly higher tidal volume or raised intracranial pressure and brain damage? In terms of cerebral blood flow versus mean arterial pressure, as I said earlier, your cerebral perfusion pressure is what you're really interested in here. Your mean arterial pressure minus your ICP will give you that value. If you don't have ICP monitoring in place though, there is still a blood pressure target you should be shooting for. A systolic pressure greater than 100 for people between 50 and 60 years old, or greater than 110 if they're without those ranges. To do this, you'll be titrating fluids, vasopressors and inotropes for your patient. For glucose, you're looking to balance nutrition and for your patient potentially insulin as well to get a glucose level between 6 and 10 millimoles per litre. You may potentially need intravenous dextrose if your patient is hypoglycemic. You do not want to expose an injured brain to hypoglycemia and further risk of injury. We would typically recommend, where I work anyway, using a low volume of a concentrated intravenous dextrose solution rather than high volumes of dilute dextrose to give IV sugar to our patients if necessary. If you give high volumes of dilute dextrose, while you're certainly getting the sugar into the patient and correcting their hypoglycemia, you will be giving them quite a significant water load, which could potentially worsen edema within the brain. It is critically important, as I say, to avoid hypoglycemia, but also to avoid hyperglycemia. Your brain will auto-regulate its blood flow to ensure that more metabolically active areas have adequate blood flow. This is known as flow metabolism coupling. So if we can reduce the brain's metabolic needs, we can therefore reduce the required blood flow, therefore blood volume, and so we can lower ICP as well. And this is about doing two things well for your patients. The first is to optimize sedatives, and the second is to have a very low threshold for considering seizures in traumatic brain injury patients and going ahead and treating them. We know that an increase in temperature causes an increase in intracranial pressure, and this is due to the increase in cerebral metabolic rate of oxygen consumption with pyrexia, your CMRO2. If you cool a patient, you can reduce CMRO2. So 6 to 7% fall in CMRO2 per degree Celsius cooling that you institute for your patient. And with that, you get a proportionate fall in cerebral blood flow, therefore blood volume, and therefore ICP. It is certainly true that induced hypothermia does lead to a reduction in intracranial pressure, but that has been shown in a high quality, large study, Eurotherm, that does not translate into better outcomes for your patients, and in fact you put your patient at more risk of cardiac arrhythmias, infection, and other adverse outcomes. And therefore what we're looking for in traumatic brain injury is maintenance of a normal body temperature. So let's say you've set all of those things into target range and intracranial pressure is still high. Well, go and examine your patient. Are that patient's pupils still equal and reactive? If not, get on the phone to your neurosurgeon immediately. You could be looking at new intracranial pathology that needs surgical intervention. If they are, though, check the basics with your patient. Are they adequately sedated? Have you got them head up? Has that tube tie been tied too tightly around the neck, potentially obstructing venous drainage? Is that cervical collar you've got in place because of the cervical spine injury poorly fitting and again obstructing venous drainage? Are they having a seizure? It can be very difficult to spot fits in patients with traumatic brain injury. When they're under sedation, you may not see them shaking, so you've got to have a high index of suspicion for them. Seizures should be suspected if you're seeing sudden, unprovoked spikes in intracranial pressure, and they can be very difficult to pick up at the bedside. Monitoring from neurophysiology will be very helpful for you there. Prophylaxis with drugs like phenytoin or levetiracetam or sodium valproate is not recommended in treating patients with traumatic brain injury. If all that's okay and the intracranial pressure is still high, you need senior multidisciplinary help, and that's going to be critical care, almost certainly a trip to scan and talking to a neuroradiologist. Are you looking at bleeding or rebleeding or new obstructive hydrocephalus? And then speaking with your neurosurgeons, is there anything they can do to help reduce intracranial pressure for that patient and hopefully improve their outcome? There are additional therapies available. Within our own centre, we would typically add muscle relaxation at this kind of point, where it may help with ventilation and venous drainage from the head. We will typically use hypertonic saline in an attempt to reduce cerebral edema. We will occasionally use mannitol to help transiently reduce ICP, although it is at the risk of hypotension because it causes such a massive osmotic diuresis. And we will also institute a barbiturate coma with thiopentone or thiopental infusion to achieve burst suppression, which means you're going to need some neurophysiology monitoring as well. The final option available to your patient is a decompressive craniectomy and or lobectomy. The evidence for this intervention is not strong. There have been two very large trials published recently Rescue ICP concluded that a decompressive craniectomy will prevent death, but at the expense of what will likely be significant disability for your patient. And the DECRA study actually found worse outcomes in the surgical group. And you also, having removed a bone flap from the patient, will also need to consider a cranioplasty and the risks associated with follow-up procedures too. So today then, we've looked at indications for intracranial pressure monitoring, how we can do it, targets for traumatic brain injury, and some of the therapies that you can institute for intracranial hypertension. If you do have any comments or questions, please leave them down below. Thank you very much for watching. I hope to see you on the next one.